Sriram's point is very well taken. Actually, in spite of repeated counseling with the urology colleagues, they don't agree to early removal of urine catheter. Their argument is that early removal will delay or hamper the recovery or healing of the neocyst transformation. They want to keep the bladder deflated. We keep trying to convince upon them.
I agree with what he says. They presented our data. Those with stent had a higher urinary tract. Well-known surgeons don't accept it, and they gave us a suggestion. They said you tie the police catheter to the stent and pull off, and we had disaster on Sunday, so we left. That's the part. It's a very good presentation. I was complimenting you on that large number. And a very one interesting point was there. I want you to look at it. Said SAMe infection was associated with interstitial fibrosis.
Yes, sir.
How do you correlate? Is it just one of statistical correlation?
It was significant correlation.
So wants to know how to explain association.
When we refer to literature, actually there is SAMe infection. Some studies have shown that increased risk of death also in some studies. There's no explanation. Maybe SAMe infection is associated with CME infection also. Correlation is we have shown that CME infection is so co-infections are more. So that way we can explain.
Any more questions? If there are no questions, we conclude this free paper session. Thank you, chairpersons.
Madam, sir.
Spectrum of AKI is changing in our practice. Simultaneously, pregnancy in India is also going through a lot of changes in terms of aging mothers and also relatively lesser in number on a national level. And simultaneously, medical complications in pregnancy are increasing. And this is a challenging area. I think from a conference perspective, I should tell you, there were about 3 or 4 of AKI in pregnancy in this particular conference. So I guess it's gaining importance in that context. That's just a backdrop to introduce Dr. Subramaniam. He is faculty at SRM Medical College in Kochi, which is a private medical college. He's he trained out of the AM program at Madras Medical College under Dr. Jayakumar. He's highly recommended as an excellent speaker. Over to Dr. Subramaniam.
Thank you very much, sir, for those kind words of introduction. So I am here to present the last CME of this conference that's going to be on acute kidney injury in pregnancy. So before we go into the pathophysiology of acute kidney injury in pregnancy, I think it is important to review the physiological adaptations that happen during pregnancy with respect to the kidney. So the kidney increases in size by about 1 to 1.5 centimeter and in volume by about 30%. And there is also a physiological dilatation of the pelvic aneurysm system due to the relaxing effect of progesterone. And this is more pronounced on the right side because of the compression of the ureter and the pelvic tube by the gravity uterus. And by third trimester, about 80% of the women develop hypernephrosis. With respect to systemic hemodynamics, there is an expansion of the extracellular fluid volume, plasma volume, by 32 to 34 weeks of gestation. The plasma volume increases by about 1.2 per liter. And there is also a concomitant increase in the red cell mass. However, this is lesser when compared to the expansion of the plasma. As a result, there is hemodilution and anemia in pregnancy. The BP falls during pregnancy, and this is most pronounced in the second trimester. By around 20 weeks of gestation, the nadir of blood pressure happens. From 20 weeks onwards, the blood pressure starts to rise, and by term, it reaches the pre-pregnant level. The most important factor that contributes to this fall in blood pressure during pregnancy is systemic vasodilatation. So pregnancy is characterized by a systemic as well as a renal vasodilatation, and there are several factors which contribute to the systemic vasodilatation. The vasculation in pregnancy becomes hyper-responsive to the stressors like vasopressin, angiotensin II, and noradrenaline. And relaxin is a hormone that's very peculiar to pregnancy. It is produced by the corpus luteum under the influence of human chorionic gonadotropin, and it produces a global and renal vasodilatation by inducing nitric oxide synthesis in the endothelium. The third important contributor to systemic vasodilatation in pregnancy is the fetoplacental unit. So this is a schematic representation. On the left side, you find the So on the left side, you find the placenta, and on the right side, you find the uterine myometrium. So during the process of placentation, the cytotrophoblast in the placenta invades the muscular spiral artery in the uterus, and it transforms into a sinusoid, a high-flow low-resistance system, and this establishes a good blood flow to the placenta. Once this is established, the placenta elaborates several growth factors, like the vascular endothelial growth factor and placental growth factor. VEGF has got systemic effects. It's a potent vasodilator, and VEGF is required for maintaining the endothelial integrity in several vascular beds. In the glomerulus, the podocytes produce VEGF, and that maintains the endothelial integrity, especially the chemistry of the endothelium is maintained by VEGF. So these are the three important contributors to the systemic vasodilatation in pregnancy. The cardiac output also increases during pregnancy. The peak cardiac output, it happens in the third trimester. Cardiac output increases by as much as 50%. That's mainly because of the falling systemic vascular resistance. The GFR starts to increase from the very early pregnancy, and it increases by as much as 50%. So in the third trimester, the GFR peaks, and it increases to 150 ml per minute or even higher. And this is mainly due to the renal vasodilatation and an increase in the renal plasma flow. However, the increase in renal plasma flow is much higher. As a result, the filtration fraction is low in pregnancy. So keeping all these physiological adaptations in mind, we can also understand the biochemical alterations that we commonly come across in the tests that are performed. So there is hemodilution, as already alluded, and the plasma osmolality falls during pregnancy. That's because of the lowering of the osmotic set point. Because of increase in GFR, the serum creatinine level in pregnancy is low. It's normally 0.3 or 0.6 milligram. And creatinine more than 0.8 milligram per deciliter should be regarded as abnormal in pregnancy. Likewise, the uric acid clearance also increases in pregnancy due to increase in GFR. So the normal uric acid level in pregnancy is around 4 milligram. Anything more than 4 milligram should be regarded as abnormal. So keeping all these physiological adaptations in mind, let's now go into the topic proper. So AKI, acute kidney injury in pregnancy. Globally, there has been a decline in the incidence of acute kidney injury in pregnancy. That's mainly because of an improved obstetric care and because of a reduction in the incidence of septic abortion. And in the developed countries, 1 in 20,000 pregnancies is complicated by acute kidney injury. And during pregnancy, AKI has got a bimodal distribution. The first peak occurs between 7th and 8th weeks of gestation. That's mainly due to hyperemesis and septic abortion. And the second peak, it occurs between 32 to 36 weeks. That's mainly related to preeclampsia and its complications. As far as the Indian scenario of acute kidney injury in pregnancy is concerned, this is the data from Varanasi. Between 1982 to 91, acute kidney injury, obstetric AKI, it accounted for about 15% of the total AKI. In the next decade, that is between 1992 to 2002, obstetric AKI contributed to only 10% of all the acute kidney injury. And this is data from Madras Medical College. Between 87 to 91 and 95 to 2004, the proportion of all the AKI with obstetric causes had remained almost the same. It's around 9%. So this is the data from across the country. What we can observe is over the last 2 decades, the incidence of obstetric acute kidney injury has been showing a declining trend. Likewise, there has been, more strikingly, there has been a reduction in the incidence of septic abortion associated acute kidney injury from various publications is evident. So the same is reflected in the histology. The incidence of acute cortical necrosis in the histopathology of obstetric AKI also has been showing a decline. Between 82 to 91 it was around 17%, and between 92 to 2002 it had come down to 2.4%. So this is the outcome that has been published from across the country. So what is obvious is the approximate maternal mortality due to obstetric AKI is around 20%, and about 53% recover completely renal function, and about 10% recover partially recover renal function, and another 20% they do not recover any amount of renal function. Coming to the etiology of acute kidney injury in pregnancy, the etiology can be classified according to the time frame. So in the early pregnancy, the before 20 weeks of gestation, hyperemesis gravidarum or septic abortion are the commonest cause of acute kidney injury. And in the late pregnancy, that is after 20 weeks, the two most important causes include preeclampsia and abruptio placenta. The other causes of acute kidney injury in the late pregnancy include acute fatty liver of pregnancy, disseminated intravascular coagulation related to intrauterine fetal death, amniotic fluid embolism, and polyamnionitis. AK can occur in the postpartum period also, so it's due to postpartum hemorrhage, puerperal sepsis, postpartum renal failure, so-called postpartum hemolytic uremic syndrome, and postpartum eclampsia. These are causes of acute kidney injury in the postpartum period. And irrespective of the duration of pregnancy, there are some conditions which can produce acute kidney injury. They include acute pyelonephritis and sepsis. TTP, even though the most commonly occurs in the second trimester of pregnancy before 24 weeks, it can occur at any time of pregnancy, thrombotic thrombocytopenic purpura. And conditions that are not specific for pregnancy, like drug-induced AKI, presenting glomerulonephritis, can all occur at any time of pregnancy. The other way to classify the etiology of acute kidney injury in pregnancy is based upon the pathogenesis. Pre-renal causes include hyperemesis gravidarum and obstetric hemorrhage. Among the intrinsic renal causes, conditions that produce acute tubular necrosis include sepsis, obstetric hemorrhage, and preeclampsia. Conditions that produce cortical necrosis include septic abortion and abruption. Conditions associated with microangiopathy include TTP-HS and HELLP syndrome, and glomerulonephritis could be due to flare-up of lupus in pregnancy. Among the post-renal cause, the overdistension syndrome is an exaggerated physiological dilatation of the pelvic axial system that results in acute kidney injury. So, coming to the renal histology, the commonest renal histology in obstetric AKI is APM. The other histologies that could be encountered include cortical necrosis, microangiopathy, glomerulonephritis, and acute interstitial nephritis, which are all rare. So, now coming to specific conditions, sepsis-induced acute kidney injury in pregnancy. The common sources of sepsis in pregnancy include septic abortion, acute pyelonephritis, chorioamnionitis, and endometritis. So, septic abortion is defined as an infection of the uterus and the surrounding tissue that follows an induced abortion, usually an illicit abortion, and it is of polymicrobial etiology. The organisms are derived from the resident flora of the genital tract. Most commonly, it's a combination of Clostridium species, Streptococcus species, and gram-negative bacilli. And these patients with septic abortion are prone to develop acute cortical necrosis. So there is a specific vulnerability to the vascular effects of endotoxin in pregnancy. This is what is known as Schwarzman phenomenon. And this contributes to the occurrence of cortical necrosis. In experimental animal models, it's been shown that in non-pregnant animals, 2 doses of endotoxin are required to induce cortical necrosis. A priming dose followed by a second dose. Whereas in pregnant animals, the priming dose is not necessary and a single dose can induce cortical necrosis. So this specific vulnerability in pregnancy to the endotoxin-mediated cortical necrosis is known as Schwarzman reaction. The clinical presentation is characterized by onset of abdominal pain, vaginal bleeding, fever and vomiting following an induced abortion, and the clinical picture is dominated with features of sepsis, septic shock, multi-organ failure, and trial of disseminated intravascular coagulation. And the AK is a part of multi-organ failure. And there is a peculiar bronze discoloration to the skin, which many of us could have observed. That's because of a hemolytic jaundice, anemia and cyanosis, and exhale and sometimes breathe air in or surrounding the uterus. The histology may trigger ATM, cortical necrosis and septic abortion, and the management is supported with volume resuscitation, hemodynamic support, and a time-honored antibiotic regimen is penicillin, clindamycin, and aminobutyric acid combination. An important obstetric aspect of management is to evacuate the uterus of immediate products of conception. Coming to preeclampsia and HELLP syndrome, preeclampsia complicates about 10 to 15% of all the pregnancies. And on the one side, while the incidence of septic abortion is declining, the proportion of acute kidney injury that is contributed by preeclampsia and its attendant complications has been showing an increasing trend. And about 30 to 40% of patients with severe preeclampsia and HELLP syndrome, that is 30 to 40% of all the obstetric AKI is due to severe preeclampsia and HELLP syndrome. And as all of us know, preeclampsia is characterized by new onset of hypertension after 20 weeks and proteinuria more than 300 mg after 24 hours. So this is the pathogenesis. This is the normal fetoplacental unit. So normally there is a cytotropoplastic invasion of the uterine spiral transforms it into a high flow, low resistance system. This is defective in preeclampsia. As a result, the blood flow to the placenta is inadequate. So the placenta ischemic. So that is the first step. So the upper panel indicates a healthy placenta which elaborates vascular endothelial growth factor, which goes and attaches itself with its receptors in the vascular endothelium. So that mediates vasodilatation and maintains the anticoagulant nature of the vascular endothelium. So in the second panel, in the lower panel, you see the preeclamptic placenta, which is ischemic, and it elaborates soluble effluents like tyrosine kinase 1, SFLT1. This acts as a soluble receptor for VEGF. It binds VEGF in the circulation and it neutralizes VEGF, so VEGF cannot bind to its vascular receptors. As a result, the endothelium acquires procoagulant properties, and there is a propensity for vasoconstriction. So this is the basic pathogenesis. In normal pregnancy, there is vasodilatation, there is renal vasodilatation, there is an increase in GFR. Whereas the preeclamptic state is normal vasodilatation, does not happen. There is vasoconstriction and there is impairment of the renal blood flow, does not get augmented as much as in a normal pregnancy. So to put everything in a nutshell, several factors like genetic, environmental and immunological factors, they result in abnormal placentation. So placenta becomes ischemic and it elaborates SFLT1, which antagonizes the vascular effects of VEGF. So this results in systemic vascular dysfunction. As a result, there is proteinuria and glomerular endotheliosis. That's because VEGF is necessary for maintaining the endothelium in the glomeruli. The fenestra is maintained by VEGF. So whenever VEGF is antagonized, the endothelial cells swell up. They accrue the capillary lumen. This process is known as glomerular endotheliosis. Hypertension occurs because of the systemic vascular dysfunction. Coagulation abnormality because of the procoagulant state. And eclampsia because of the loss of blood-brain barrier. So even though the GFR does not increase in preeclampsia as much as normal pregnancy, it is still higher than the pre-pregnant value. So as such, acute kidney injury is rare in preeclampsia. Only about 1% of all patients with preeclampsia develop acute kidney injury. Acute kidney injury to occur in preeclampsia, there should be a coexisting problem. Like patients should develop abruption placenta, or there should be a HELLP syndrome, or patients should have developed hormone depletion due to use of diuretics, or there should be a pre-existing chronic kidney disease. So HELLP syndrome is an important cause of acute kidney injury in the setting of preeclampsia, and HELLP stands for hemolysis, elevated liver enzyme, and low platelet count. So this is a state of microangiopathy and coagulopathy that happens during the preeclamptic state. So there is evidence of microangiopathic hemolysis. So in the peripheral smear, you will find the fragmented RBCs. There will be elevated LDH and low plasma haptoglobin. That's usually less than 25 mg per deciliter. And there is elevated liver enzyme due to occlusion of the microcirculation in the liver, and the thrombocytopenia is usually less than 1 lakh per cubic millimeter. Thrombocytopenia is often the first sign of HELLP syndrome. So the other signs might follow that. So any pregnant lady with isolated thrombocytopenia, HELLP syndrome should be included in the differential diagnosis. So the common clinical features include a right upper quadrant pain, headache, nausea and vomiting, and about 7% to 10% of patients with HELLP syndrome develop acute kidney injury. So this is one of the important dreaded complications of HELLP syndrome. So subcapsular liver hematoma sometimes can rupture into the peritoneum and can threaten the life. Multiple liver infarcts, that's because of occlusion of the microcirculation due to microangiopathy. The other complications of HELLP syndrome include obstruction, pulmonary edema, and disseminated intravascular coagulation. So whenever a preeclamptic patient develops acute kidney injury, there is a high chance of maternal mortality. It's about 13%. And patients with preeclampsia and acute kidney injury are prone for pulmonary edema, and the mainstay of treatment of preeclampsia with AKA is to expedite the delivery. So delivery of the fetus in the placenta is the mainstay of treatment. So for that matter, any severe form of preeclampsia, immediate management should be to expedite the delivery. Antihypertensives and magnesium sulfate have got a role to play, and about 30% of patients with HELLP syndrome and acute kidney injury they require dialysis, and the recovery of renal function is usually complete following delivery. So coming to thrombotic microangiopathies, among the various thrombotic microangiopathies that could be encountered in pregnancy, we have hemolytic uremic syndrome, TTP, the HELLP syndrome, and rarely antiphospholipid antibody syndrome. So the basic abnormality in thrombotic microangiopathy is an endothelial damage, so that promotes platelet thrombin formation in the microcirculation, and as a result, there is ischemia to the organ. So that is the basic abnormality. In hemolytic uremic syndrome, it is the renal microcirculation that is predominantly affected, whereas in thrombotic thrombocytopenic purpura, the involvement of microcirculation is more widespread with involvement of multiple organs with the predilection for the involvement of CNS microcirculation. So CNS manifestations predominate in TTP. So as I already said, TTP can present at any time of pregnancy, but it's most commonly in the second trimester, that's before 24 weeks of gestation. And TTP can develop de novo in pregnancy, or pregnancy can precipitate relapse of pre-existing TTP. And it's mainly due to an increase in pro-cavernous factors during pregnancy. And the ADAMTS13, which is a 1 milligram factor protease, also falls during pregnancy. That might be the reason for development of TTP during pregnancy. So clinical pictures dominated by CNS manifestations in lethargy, confusion, focal neurological episode, seizure, and even coma. And about 30 to 80% of patients with TTP can develop AKA. The mainstay of management is plasma exchange. Delivery of the fetus of the placenta does not influence the outcome. There is no role for, in the sense, does not influence the renal outcome in TTP. So low dose aspirin, dipyridamole, and steroids have been used with variable results in TTP. And with plasma exchange, usually the recovery of renal function is good in TTP. HUS is also referred as postpartum malignant nephrosclerosis or postpartum renal failure. And the usual time of presentation is in the postpartum period, but sometimes it can present before delivery near term. In several etiological factors have been implicated: viral infection, retained bits of placenta, oxytocin drugs, and immune mechanisms, because it's been found that many patients with postpartum HUS have a low complement 3 level. So that means there could be an activation of the alternate complement pathway. So usually following delivery, patients present with sudden onset of polyuria or anemia, and hypertension and sometimes very much pronounced, resulting in intracerebral hemorrhage. And the renal failure is usually severe, and about 60% land up with end-stage renal disease in 3 months' time. So the renal outcome is highly unfavorable in postpartum hemorrhagic epidemic syndrome. So the overall prognosis also is guarded. Maternal mortality is about 20 to 40%. Coming to acute fatty liver of pregnancy, it's a disease of the third trimester, and it affects about 1 in 10,000 to 1 in 20,000 pregnancy. See, the basic pathology or pathogenesis in acute fatty liver of pregnancy is a defect in the enzyme 3-hydroxyacyl-CoA dehydrogenase. This enzyme is necessary for metabolizing the long-chain fatty acids. So, and this mutation is expressed only in a homozygous state. So, it is an autosomal recessive disorder, and it is expressed only in the homozygous state. So, in the non-pregnant state, a female who had a heterozygous mutation would have remained normal, but after conception, the placenta starts to generate a lot of long-chain fatty acids. So, there is increased availability of substrate, and the disease gets expressed even in the heterozygous state. So, that is why patients develop acute fatty liver pregnancy only during pregnancy. So, the long-chain fatty acids, they accumulate and they are toxic to the liver. They produce microvesicular steatosis. The clinical picture is dominated by acute liver failure patients present with jaundice, hepatic encephalopathy, and enzymes will be very high, sometimes even more than thousands. The aspartate aminotransferase is more than 1,000 units, and coagulopathy is a hallmark of acute fatty liver pregnancy. So, if you do the